Hi everyone, welcome back to the channel. Today we have the long-awaited reproductive video. Like the previous videos, I'll be describing a vignette, take a few seconds to try to guess the diagnosis. Let's get started. So first we'll be talking about errors in fetal development. So the first condition, we have amniotic band constriction in limb tissue of the fetus. So this is disruption. Next, we have a baby born with club feet. So this is deformation. Next, we have oligohydramnios leading to lung hypoplasia and facial and limb deformities. This is going to be a sequence. And remember, this is Potter's sequence. Next, we have a medication taken by a mother during pregnancy that causes renal failure in the baby. So this is going to be ACE inhibitors. An example of this is lisinopril. Next, we have a medication that causes vaginal clear cell carcinoma. So this is DES. Next, we have an antibiotic that causes cartilage damage. So these are the fluoroquinolones. An example of this is levofloxacin. Next, we have a medication taken by the mother that causes discolored teeth in the baby. These are the tetracyclines. Next, we have a medication that causes tricuspid valve abnormalities. And this is lithium. Remember, lithium is a medication used for bipolar disorder, and the tricuspid valve abnormalities is known as Ebstein's anomaly. Next, we have a medication that causes limb defects. This is thalidomide. Next, we have a condition where the baby is born with thin vermilion border, smooth philtrum, and a small palpebral fissure. So this is fetal alcohol syndrome. Next, we have a big baby born with caudal regression, hypoglycemia at birth, and neural tube defects. So this is diabetes. Next, we have a newborn with high-pitched crying, sneezing, diarrhea, and tachypnea. So this is neonatal abstinence syndrome. Next, we have a baby that has inability to swallow amniotic fluid due to esophageal atresia or anencephaly. So this is polyhydramnios. Next, we have an inability to excrete urine due to renal agenesis. So this is oligohydramnios. Next, we have one twin who's smaller, that presents with hypovolemia, and the other twin is bigger with hypervolemia. So this is twin-twin transfusion syndrome. Remember, there's a donor twin that has the hypovolemia and oligohydramnios, and then the recipient twin has the hypervolemia and polyhydramnios. And this happens due to unbalanced vascular connections between the twins that have a shared placenta. So one twin has blood flow to the other twin, hence the volume differences. Next, we have yellow colored discharge from the umbilicus. This is a patent urachus. Next, we have failure of the vitelline omphalomesenteric duct to obliterate, and the patient presents with abdominal pain and blood in the stool. So this is Meckel's diverticulum. Next, we have a lateral neck mass anterior to the sternocleidomastoid muscle. So this is a pharyngeal cleft cyst. Next, we have a sequence that leads to small jaw, cleft palate, and airway obstruction. So this is Pierre-Robin sequence. Next, we have a first and second pharyngeal arch defect, and the patient's going to have facial and hearing defects. So this is Treacher-Collins syndrome. Next, we're going to have third and fourth pharyngeal pouch defects, cleft lip and cardiac issues, a lack of thymus, and low calcium. So this is DeGeorge syndrome. Now we have failure of the paramesonephric ducts to fuse, leading to a double uterus. So this is uterine didelphys. Next, we have an abnormal opening of the urethra on the ventral surface of the penis associated with inguinal hernia and cryptorchidism. So this is hypospadia. Next, we have an abnormal opening of the urethra on the dorsal surface of the penis. So this is epispadia. Next, we have sudden pelvic pain, nausea, vomiting, and this happens due to twisting around the infundibulopelvic and ovarian ligament. So this is ovarian torsion. Next, we have an obese female with multiple childbirths and has protruding anterior vaginal bulge. So this is a cystocele. Remember, the cystocele is when we have the bladder that's protruding beyond the pelvic organs. Next, we have flank bruising, pain, and hematuria after a motor vehicle accident, and we have rib number 12 injured. So this is a renal injury. Next, we have suprapubic pain, hematuria, and difficulty urinating after a motor vehicle accident, and we have an intraperitoneal urine collection. So this is a superior bladder injury. This is usually compared to the next one where you have suprapubic pain, hematuria, and difficulty urinating after a pelvic fracture as well, but now it's an extraperitoneal urine collection. So this is an anterior bladder injury. Next, we have a male with blood at the urethral meatus and difficulty urinating after falling on top of a fence or bike, which we call a straddle injury. And then there's going to be injury of the spongy, also known as the bulbar urethra. So this is an anterior urethral injury. This is often compared to a male with blood at the urethral meatus and has difficulty urinating after a pelvic fracture, but this time there's injury of the bulbomembranous urethra. So this is going to be a posterior urethral injury. Now we have infertility due to ciliary dyskinesia. So this is Cartagener syndrome. The next condition is going to cause infertility due to absence of the vas deferens. So this is cystic fibrosis. Next, we have abdominal pelvic pain midway through the menstrual cycle. So this is Mittelschmerz. Next, we're going to have a pregnant female who gets respiratory alkalosis, increased GFR, and cardiac output, as well as skin hyperpigmentation. So this is normal pregnancy. Now, some questions are going to try to confuse you and give you all of these changes that happen, but remember, this is natural, normal physiologic response to pregnancy to keep up with the demands of the pregnancy itself. Next, we have a 52-year-old female with hot flashes, insomnia, and weight gain. Labs are going to reveal low estrogen and a high FSH level. So this is menopause. Next, we have a condition where we see a tall male with small, firm testes, gynecomastia, and this happens due to abnormal Sertolian Leydig cells. And on labs, we see a high LH and high FSH. So this is Klinefelter syndrome. And here, the patient is going to have an extra X chromosome. And so these males are going to appear more feminine with the breast enlargement, and they're at actually increased risk of breast cancer as well. And, they might have infertility, female hair distribution. So look out for all of those symptoms. Next, we're going to have a short female with widely spaced nipples, fibrotic ovaries, and this condition can be associated with coarctation of the aorta, bicuspid aortic valve, and fused kidneys, also known as horseshoe kidney. So this is going to be Turner syndrome. And here, they're missing one of their X chromosomes. Next, we have a patient who is lacking puberty and can't smell properly. They're going to have a low GnRH, LH, and FSH. So this is Kalman syndrome. Now remember, in Kalman syndrome, it's a form of hypogonadotropic hypogonadism, and it happens due to defective migration of the neurons and failure of the olfactory bulbs to develop. So the smell issues here are very, very important. Next, we have a pregnant female who grows coarse facial hair, and the newborn baby girl is born with ambiguous genitalia. So this is placental aromatase deficiency. Next, we have a female patient without menses, lack of pubic and axillary hair, a blind-ended vagina, and male levels of testosterone and DHT. So this is androgen insensitivity syndrome. Remember here, they actually have 46 chromosomes with XY, but because the body is insensitive to the androgens, they appear female. So they're going to come in at the time of puberty and they're going to be like, what's going on? Why haven't I reached puberty? And then further workup is going to, show these symptoms and the XY chromosome. And then really important here, again, amenorrhea, blinded vagina, scant pubic and axillary hair, and they appear female, but they're going to have the male testosterone and DHT levels. Okay, next we have a female patient who gets a deep voice and penis growth at puberty. They're going to have high testosterone levels but low DHT levels. B5 alpha reductase deficiency. Here, the patient appears female as well. However, they are 46XY chromosomes, so they should be male, but because this enzyme isn't working, which remember converts testosterone to DHT, they don't have any DHT forming and they can't form the male external genitalia, which is why they appear female. At puberty, the testosterone spikes and they get virilization of the external features, the voice is going to deepen, and this is why we see this sort of presentation. Next, we're going to go over some pregnancy complications. So, in the first one, there's going to be a pregnant patient who has a painful, tender uterus, bleeding. She might have been in a motor vehicle accident. They might mention smoking or cocaine use. So this is abruptio placenta. Next, we have a painless, non-tender uterus. And there's also bleeding in this one as well. So this is placenta accreta. Next, we're going to have a painless, non-tender uterus, bleeding as well. But this time we see a low-lying placenta on prenatal ultrasound. So this is placenta previa. And the way I remember this one is you kind of get a preview of the placenta, right? We see the placenta on the ultrasound, so that's how I remember placenta previa. Remember abruptio placenta, I kind of think of like abrupt, sudden, painful bleeding. For placenta accreta, this is the one where the placenta is abnormally attached. And when the baby's being delivered, we get this abnormal bleeding. And then placenta previa, again, this is the one with the low-lying placenta that we see on ultrasound. This one's also painless and non-tender. So really try to know how to differentiate these three. Next, we have painless bleeding before childbirth, fetal bradycardia, and velamentous cord insertion. So this is going to be vasa previa. And this is when the fetal vessels run over or really close to the cervical os, and this can result in this bleeding. Next, we have heavy bleeding after childbirth. So this is postpartum hemorrhage. And here, remember, the most common reason this happens is due to uterine atony, where you have a soft, boggy uterus that's not contracting properly, and we get this persistent, heavy bleeding. And remember, the important thing here is to do a uterine massage. You can give oxytocin, and sometimes in more serious cases, you have to ligate the internal iliac artery to preserve fertility, but also stop the bleeding. Next, we have sudden pelvic pain and bleeding and no fetus in the uterus. So this is an ectopic pregnancy. And remember, this is when the fertilized ova basically implants in somewhere other than in the uterus. And most often, remember, it's the ampulla of the fallopian tube, which is where the fetus implants. And so you sometimes feel an annexal mass, but the beta HCG is going to be positive. However, it's just in the wrong location. Next, we have vaginal bleeding, emesis, uterus that's large for dates, elevated HCG, 46 chromosomes, and we see a cluster of grapes or a snowstorm appearance. So this is a complete mole. The next one is often compared to a complete mole. This time we see vaginal bleeding, emesis, uterus large for dates, elevated HCG. This time we have 69 chromosomes, P57, maternal genetic material, and fetal parts are visible. So this is a partial mole. And I like to remember fetal parts in partial mole. Next, we have shortness of breath and hemoptysis after pregnancy and very high HCG levels. So this is choriocarcinoma. And remember here, we have malignant trophoblastic tissue, remember comprising of the cytotrophoblasts and cytiotrophoblasts, and a lot of the times it metastasizes to the lungs, so we see multiple nodules in the lungs. Okay, next we have some blood pressure conditions now. So the first one is elevated blood pressure over 20 weeks, no history of hypertension, no end organ damage, no proteinuria. And we usually treat this with hydralazine, labetalol, nifedipine, or methyl-dopa. So this is gestational hypertension. Next, we have new hypertension with proteinuria or end organ damage after 20 weeks. It's due to endothelial dysfunction and vasoconstriction, and we treat it with BP meds, IV magnesium to prevent seizures, and then ultimately we deliver the baby. So this is preeclampsia. Next, we have elevated blood pressure along with the seizure. We treat it with IV magnesium, blood pressure medications, and immediate delivery. So this is eclampsia. Next, we have hemolysis, elevated liver enzymes, low platelet count. We see schistocytes on the blood smear, and we have to immediately deliver the baby. So this is HELP syndrome. Next, we have a pregnant patient who gets hypotensive when lying down, and this happens due to compression of the aorta and IVC by the uterus. So this is supine hypotensive syndrome. Remember, when the patient lays down, the uterus compresses the IVC, which decreases venous return, which leads to decreased blood pressure. Next, we have a bump or swelling on the labia majora. So this is a Bartholin cyst or abscess. Next, we have a postmenopausal female with white plaque or erosion on the vulva. This is lichen sclerosis. Next, we have a rough plaque on the vulva. A younger patient will have HPV 16 or 18 as the cause, and an elder patient will have a history of lichen sclerosis. So this is vulvar or cervical carcinoma. Next, we have a red crusted lesion on the vulvar area. This is Paget's disease. Next, we have a young female with cyclic pain each month lasting for a few days. An exam is going to show a vaginal bulge. This is going to be an imperforate hymen. Next, we're going to have a vaginal tumor in a patient with DEX exposure or vaginal adenosis. This is clear cell carcinoma. Next, we're going to have a little girl with a grape-like mass protruding from the vagina. So this is sarcoma botuloides. Next, we have menopause in a patient less than 40 years old, and we usually work it up with a karyotype screen. This is primary ovarian insufficiency, also called premature ovarian failure. And remember, signs of menopause, we see that the menses stop for at least a year, the estrogen levels are low, and the LH and FSH are elevated. Next, we have a female athlete who stops getting her menses. This is associated with bone weakness and fractures. So this is functional hypothalamic amenorrhea. This is often seen in patients who exercise really hard, patients with like anorexia. It shuts down the whole cascade and we get decreased GnRH, decreased LH and FSH, and that leads to a low estrogen level, which is why we get bone issues and the menstrual issues as well. Next, we have menstrual irregularities in a female with an elevated BMI, acne, hirsutism, and then we see enlarged ovaries and cysts on ultrasound. So this is polycystic ovarian syndrome, PCOS. Remember, this is also associated with endometrial hyperplasia and endometrial cancer, diabetes, and so a lot of these conditions we have to manage and treat. Next, we're going to have painful menses, and the treatment for this is NSAIDs. So this is primary dysmenorrhea, and NSAIDs are useful here because the pain is mediated by prostaglandins, which is blocked by NSAIDs. Next, we have bloating, pelvic fullness. It's the most common malignant ovarian cancer, and we see psammoma bodies on histology. So this is serous ovarian cancer. Next, we have a young female with a mass that reveals teeth and hair, and this mass can lead to torsion. So this is a teratoma. Next, we have an adolescent with an ovarian tumor that has a fried egg appearance, and we see elevated HCG and LDH. This is a dysgerminoma. Next, we have a tumor that has Schiller-Duval bodies and an elevated AFP. This is a yolk sac tumor. Next, we have a tumor that has spindle-shaped cells. It can be associated with Meigs syndrome, where along with the ovarian mass, you have ascites and a pleural effusion. This is a fibroma. Next, we have an ovarian mass that produces androgens, and females can present with hirsutism, male pattern baldness, or clitoromegaly. So this is a Sertoli-Leydig cell tumor, and all this virilization happens because of the androgen production by the tumor. Next, we have a tumor that has Col-Exner bodies, and we see elevated estrogen and inhibin. So this is a granulosa cell tumor. This one often presents in females in their 50s, and because of the estrogen production, they can also have postmenopausal bleeding because remember, estrogen leads to endometrial hyperplasia, and it can lead to endometrial dysfunction and bleeding. Next, we have a uniformly enlarged uterus and uterine glands in the myometrium. So this is adenomyosis. Next, we have adhesions in the endometrium. The patient might have a history of a uterine procedure like a dilatation and curettage and can lead to decreased fertility and pregnancy loss. This is Asherman syndrome. Next, we have elevated estrogen leading to endometrial proliferation and postmenopausal bleeding. So this is endometrial hyperplasia, or it can even just be endometrial carcinoma, so look out for that. And they'll never try to really confuse you between the two. Next, we have endometrial tissue in the ovary and pain with menses and defecation. So this is endometriosis. Next, we have a patient with fever, leukocytosis, vaginal discharge after childbirth. It's usually due to Staph aureus and E. coli, and we treat it with gentamicin and clindamycin. This is endometritis. Next, we have an irregularly enlarged uterus, heavy menses, and smooth muscle proliferation. So this is fibroid, also known as leiomyoma. Next, we have a malignant smooth muscle proliferation in postmenopausal females. This is a leiomyosarcoma. Next, we have young female with breast pain and lumps at the time of her menses. This is fibrocystic change. Next, we have a painless breast lump after recent injury. This is fat necrosis. Then we have breast pain while breastfeeding due to Staph aureus infection. And to manage this, we continue breastfeeding and give antibiotics. This is lactational mastitis. Next, we have a young female with a small mobile breast lump that's well circumscribed. This is fibroadenoma. Next, we have a patient with bloody nipple discharge. So as soon as you see these words, pick intraductal papilloma. Next, we have a large breast mass, and we see leaf-like projections on histology. This is Phyllodes tumor. Next, we have a male with breast enlargement. They could have a history of Klinefelter, testicular tumor, spironolactone use, or liver cirrhosis. This is gynecomastia. And all these conditions that I mentioned all have elevated estrogen, which is why they get this gynecomastia. Next, we have a patient with palpable hard breast mass in the upper outer quadrant of the breast, usually a postmenopausal female, and we see nipple retraction and skin dimpling due to suspensory ligament involvement. This is breast cancer. The next two are going to be types of breast cancers. The first one is going to be the most common type of breast cancer, and we see glandular duct cells on histology. This is ductal carcinoma. This is often compared to the next one where we see decreased E. cadherin and we see lines of cells on histology. And this is lobular carcinoma. I just remember L for line and L for lobular to help me remember this one. Next, we have a red crusted breast lesion. So this is Paget's disease. Anytime I see red and crusted, I often think of Paget's disease, whether it's in the vulvar area or the breast area. Next, we have breast redness, warmth and swelling, the peau d'orange effect, where we see lymphatic involvement, and the reason it's called that is because it looks like an orange peel. So this is inflammatory breast cancer. Next, we're switching over to the male pathologies. So we have a patient who presents with an abnormal penis curvature, fibrous plaque in the tunica albuginea. So this is Peyronie's disease. Next, we have a patient with a prolonged persistent erection, and they might mention a depressed patient who's on trazodone. This is priapism. Other examples they can mention for this might be a patient with sickle cell disease or other medications like sildenafil. And to treat this, you have to do aspiration of the corpora, give phenylephrine, or you might even need surgical decompression to prevent ischemia. Next, we have testes that fail to descend, palpable mass in the abdomen, the patient can have fertility issues, increased risk of germ cell tumors. So this is cryptorchidism. And remember here, if they have unilateral cryptorchidism, they're going to have normal testosterone. But if it's bilateral, they actually have decreased testosterone levels. Next, we have a patient with sudden severe testicular pain, usually a young boy. They're going to have a high riding testes, absent cremasteric reflex, and no relief with elevation. And this is testicular torsion. Remember here, they're going to have the negative Pren sign, which means there's no relief with elevation, and the absent cremasteric reflex is important because it affects the genitofemoral nerve. And you need emergent surgical correction to prevent any further damage. Next, we're going to have dilated veins in the pampiniform plexus, vague of warm appearance, increases with Valsalva, no transillumination, and it's more common on the left side. This is a varicocele. And remember, it's more common in the left side due to the left gonadal vein draining into the left renal vein. Next, we have a scrotal swelling that's transilluminated due to incomplete obliteration of the processus vaginalis. This is a hydrocele. Next, we have a painless lump in the testicle that does not transilluminate. The placental ALP is elevated, and there's a fried egg appearance on histology. So this is a seminoma. Next, we have a painful hemorrhagic necrotic testicular mass with elevated HCG levels. This is an embryonal carcinoma. Next, we have elevated AFP, syncytiotrophoblasts and cytotrophoblasts are affected. This is a choriocarcinoma. Next, we have Ranke crystals, and this tumor produces androgens and estrogens. This is a Leydig cell tumor. And remember, because it produces androgens and estrogens, we can have things like precocious puberty and gynecomastia. Next, we have pain in the posterior testes, pain relief with scrotal elevation, which is a positive Pren sign. This is epididymitis. Next, we have a tender, boggy prostate. In elder males, it's going to be due to E. coli, and in younger males, it's going to be due to chlamydia and gonorrhea. So this is prostatitis. Next, we have an elder male with urinary frequency. He's going to report peeing at night. And on digital rectal exam, we see a smooth, enlarged prostate. This is benign prostatic hyperplasia, BPH. And remember, some important medications to treat this are going to be alpha antagonists like terazosin, tamsulosin that block alpha 1, which causes relaxation of the smooth muscle, which can help the males urinate properly. We can also give things like 5-alpha reductase inhibitors like finasteride. So those are all things that we can do for relief of BPH. Next, we compare this to a patient who's an elder male with urinary issues and low back pain. And on digital rectal exam, this patient's going to have an irregular nodular prostate. This is a prostate cancer. And they get the low back pain because prostate cancer often metastasizes to the bone. And in these patients, we have to get transrectal biopsy, and on histology, we see irregular glands, and we use something called the Gleason grade, and the higher the Gleason grade, the more poorly differentiated and worse the prostate cancer is. So that's it for Repro. I hope you enjoyed the video, and like always, please feel free to reach out or comment below if you have any questions, and we'll try our best to help you out as best as we can. Thank you so much for listening, and good luck studying, everyone.